I am an orthopedic surgeon. I've been at Eisenhower for over 30 years now and have enjoyed it. My specialty is lower extremity and foot and ankle surgery. And my background is I trained undergraduate. I went back east. I was at Harvard, and then I went to medical school at the University of California, San Francisco. I did my residency at UCLA in orthopedic surgery, and then I did a fellowship in foot and ankle surgery at the Mayo Clinic, Scottsdale. And since then, I've been here at Eisenhower and Desert Orthopedic Center and specialized in orthopedic surgery of the foot and ankle. So today I wanted to go over some of the latest innovations in surgery. These are actually the things I'm concentrating on are things that really were not being done 30 years ago. That's one of the exciting things about surgery and about orthopedics is that we're always learning, we're always doing new things, and it stays interesting and stays exciting. And we improve our care to patients. So foot and ankle problems. The foot and ankle, people ask, why am I a foot and ankle surgeon? Well, it's an interesting area. The foot and ankle is very complex. They're common problems of the foot and ankle. The foot and ankle has 28 bones in the foot and ankle. There's multiple small joints. The anatomy is complex. The innervation's complex. It's there's a lot of nerves in the feet. So it's a very interesting area. And the new things in foot and ankle surgery, which I'll be talking about today, total ankle replacement, which, when I started 30 years ago, total ankle replacements did not work back then and were not being done. And now it's really become the gold standard. And I'll go into that in depth. Bunion surgery innovations. Everyone have heard of bunion surgery, and I think everyone's probably heard of bunion surgery disasters, but almost everyone knows of someone who has a bunion or has had a bunion, and it's a common problem, but there's some innovations which make it a much more reliable and safe surgery nowadays. Other innovations, which I won't cover today, are arthroscopy. Knee arthroscopy and was certainly done when I started, but now we can arthroscope small joints, the ankle, other joints. We make things less invasive than they used to be. Posterior tibial tendon reconstruction, that's a whole area that's been developed over the last 30 years, really. That's the adult flat feet. A lot of us, as we get older, our feet can become flat. We lose some of the arch. The feet, you can get some deformities of the feet, and frequently that's from loss of the forces of the posterior tibial tendon, and there are things to do to reconstruct that. Fracture surgery is much better now with modern plates and screws and less invasive techniques, and obviously major reconstructive foot surgery, and that's obviously a huge topic. There's been major innovations in that. So today, one of the topics we're focusing on is arthritis of the ankle and total ankle replacement. Now, arthritis of the ankle is usually post-traumatic in nature. It's it's not spontaneous like frequently. Sometimes hip and knee arthritis is more spontaneous. It can be from injuries, but ankle arthritis, usually people can relate it to an injury, breaking their ankle. Nowadays, due to airbags and things that allow people to survive major accidents, sometimes people survive, but they do have some lower extremity injuries, which we repair. But sometimes the damage to the joint's damaged, the joints put back together, they do well for a few years, and then that joint can become arthritic due to the cartilage damage at the time. And so sometimes ankle arthritis develops 30, 40 years after a major ankle injury or chronic ankle sprains, things like that. And again, most studies show that the 80% of ankle arthritis is post-traumatic in nature, the vast majority. And ankle arthritis hits people earlier, partly because it's post-traumatic. So athletes and anyone that has ankle injuries early, if people have a bad ankle fracture, a car accident, a fall, climb, people fall from a height, things like that. If the cartilage is damaged, we can still put the joint together as perfectly, but sometimes there's permanent damage to the cartilage that the body can't repair. And that can progress, and you can lose your cartilage and the cushioning of the joint. and 20, 30 years later, you've lost that joint and it becomes arthritic. So that can happen in people's 30s or 40s. And that's, obviously when people are working in a very active time of life. So you have to look at the treatments for ankle arthritis over a long horizon and the things that are effective and last. This is a X-ray of ankle arthritis. There's no joint there. You can see it's bone on bone, and that's painful. It can be and stiff. So ankle arthritis can be in young people. It can also be in older people too, but it also can young people get post-traumatic in nature. The treatment can be challenging. The ankle joint is, you can feel your ankle. The ankles kind of bones are subcutaneous. You can feel both sides of the ankle. And, when there's, with that loss of the soft tissue envelope, you have to be careful with surgeries and other treatments. So the initial treatment for ankle arthritis, like most conditions, is conservative. A lot of people get good relief from anti-inflammatories if you tolerate them, things like ibuprofen, Advil, the natural anti-inflammatories. There's also good topical ones now. Voltaren gel is now over the counter. There's Pensade, there's Aspercreme, there's various topical anti-inflammatories which get absorbed locally and are safer because they don't have as much impact on your stomach and less chance of getting an ulcer and things like that. So people tolerate those, and frequently those are effective in the foot and ankle. Corticosteroid injections can reduce inflammation and decrease the pain, so those can help. It doesn't cure the arthritis, but that helps. Activity modification. I mean, if you have a lot of ankle arthritis, running and jumping and things like that are probably not the best activities, but swimming, less impact activities, walking, things like that are better. Braces and sleeves can help to give some support and reduce the swelling. The treatments for ankle arthritis, there's lots of treatments. There's only some that are really effective and work, but arthroscopic debridement, that's where you put a scope in there and clean it out. Like in all the other joints, really, that gives you some temporary relief from removing some of the inflammatory fluid, but it doesn't give any long-term relief, or it doesn't change the course unless there's just a focus of arthritis or cartilage loss that you can graft. Really, for most cases of arthritis, that's not effective. Sometimes people have tried putting allograft joint replacements, which means taking a cadaver joint, basically, and putting that bone, replacing your arthritic bone with that. Initially, the x-rays look very good, but that bone has to be bones living, and that bone has to be replaced with your bone. And really, those have not been shown to be effective in the long term. Sometimes if one part of the joint's wearing more than the other, we can cut the bone and redirect the pressures. That can sometimes be effective. Distraction arthroplasty, which just means we put pins in the foot and an ankle and stretch the joint and arthroscopically clean it out, and with the hope that you'll make some better cartilage. It's kind of experimental. That hasn't had any long-term effect in most people. Again, all these things that, some people, there's sporadic cases where people feel they get great results, but the average person does not. Microfracture is another arthroscopic thing where we drill holes, try to encourage fibrocartilage. Again, that hasn't been shown to be long-term effective in most cases. Things you hear about all the time, stem cell injections. Stem cells, where you take some of your they use either fat cells or bone marrow and get stem cells and inject it. That has an anti-inflammatory effect, but still, no one's ever shown that to actually grow cartilage or reverse the arthritis, but you certainly have some relief for the symptoms. The limitation of that is that it's not covered by insurance. Generally, it's very expensive, and not having any long-term proven benefit, it's not always recommended. Another thing we do here commonly is not necessarily for ankle arthritis, but for other joints, is platelet-rich plasma injections, where we take your own blood, spin it down, get some of the growth factors, and inject that in areas that are slow to heal, like the Achilles tendon, the plantar fascia, things like that. For arthritis, it could reduce some of the inflammation, but generally not a long-term effect. And again, platelet-rich plasma is generally not covered either by insurance. So moving on, the treatments for ankle arthritis, the options include arthroscopic fusion, open ankle fusion, ankle arthroplasty, or tibial-tail calcaneal fusion. Now, basically, the gold standard, certainly 20 years ago, was a fusion of the ankle. We remove the arthritic joints, we make it one bone. That gets rid of the joint, gets rid of the source of the arthritis and the pain. The disadvantage is it leaves you a stiff joint. They can do that. We can do that arthroscopically through a small incision, remove the cartilage, push the joint together and fuse it. We can do that open through a larger incision, put plates and screws. But again, the limitation of that is that the joint's stiff and people want motion. And then ankle arthroplasty, where we replace the joint with metal and plastic components, as most you're familiar with in hip and knee replacements. And still today, I get people asking me when I say something about ankle replacements, they say, I didn't know you replaced the ankle. Obviously, they're nowhere near as common as hip and knees, but the good news is, and that's why I'm giving the talk, is that they're very effective now and really become the gold standard. So this X-ray is an example just showing an ankle fusion. And, it's not a trivial surgery, but it involves removing the arthritic joint. And then we put these plate and screw, different constructs of plates and screws to hold the bones together. Then your body heals it and makes it one bone, and then gets rid of the pain. This is an example of an ankle replacement. There's several different versions, but this is an ankle replacement with the metal, and then in the middle here is a plastic polyethylene component that for low friction that resurfaces that limits the wear. And the advantage of this is that there's motion. So these are the two major options now. The fusions, there's probably over 25,000 done a year now. The other things I mentioned are less common. Total ankle replacements are increasing quite a bit. There's probably 6,000 to 8,000 a year done in the U.S. It's growing, and it's really becoming the gold standard. Not everyone's eligible for an ankle replacement. Some do require a fusion, as I'll discuss. But again, ankle replacements are very effective for those people that have ankle arthritis, but ankle arthritis is much less common than hip and knee arthritis. So, there's 800,000 hip and knee replacements done in the U.S. or more than that a year. There's only about 6,000 ankle replacements. So the advantages of a fusion, it provides good function, it's predictable pain relief. If someone says, I want one surgery that will last me the rest of my life, this is the surgery, because it's once it heals, it's going to relieve the ankle arthritis. There's always a chance of developing arthritis in other joints, though. And if there's a significant deformity or a history of infection or things like that, it's probably the way to go. And it people are very happy with that have had pain for years. The disadvantage is, by definition, it's stiff. It takes, the recovery is anywhere from 6 weeks to 3 months to get it healed. Sometimes they don't heal. They need to have occasionally further procedures to get those healed. And over the years, arthritis can develop in adjacent joints. And you can see with an ankle fusion, the other joints in the foot still move. So even though someone is worried about their ankle being stiff, the ankle doesn't move, but the other joints move and accommodate that, although that may make them more predisposed to arthritis in the future too. But again, the ankle fusion is good for the lifetime. It's for people who have had infection with poor bone stock, with a lot of other risks. It's the standard and can do well. And again, the disadvantage is that you can develop arthritis in other joints of the foot, and that's a concern. So comparing ankle fusion to ankle replacement, both give good pain relief. The advantage of an ankle replacement is that most patients report better function and by definition, better motion. An ankle replacement provides a stable, less painful foot. The range of motion is closer to your normal ankle, and it decreases the risk of arthritis in your adjacent joints. The disadvantage is that there's always a chance, like hip and knee replacements. Over the years, it can wear out. You might need to replace the plastic component. This white component is the plastic component that can wear out over the years. Sometimes the bone, if the bone weakens or the components loosen, you might need to have it revised. So there is a chance you might need more surgery in the future. Most of the time, not, but they can sometimes wear out. So the history of total ankle arthroplasty, total ankle replacement, it started in the late 1960s in the United States, just like hip and knee replacement. And hip and knee replacement was reliable and expanded rapidly. It was a great solution to those debilitating problems. I think the other issue was, hip and the treatments for hip and knee arthritis back then options were not very good. I mean, the hip and knee back then, sometimes people had you could fuse a hip, fuse a knee, but that's a bad surgery. I mean, having a stiff knee, a straight stiff knee it really limits your function, and that's not a good option. A stiff ankle, a fused ankle is, it's not like a good ankle or a total ankle, but it's not a bad thing, and it gets rid of the pain, and people's function is pretty good. But that's not true with hip and knee. But anyway, the ankle replacements also had the disadvantage of there was a high failure rate. The components loosened. It was just, the ankle bones are are thin. That you don't have as good bone stock as some other areas. The fixation and the devices weren't good then, and just they did not work very well. So they kind of stopped doing those early on. And really did not start again until this century. Total ankle replacement. Why do that rather than a fusion? Again, it's for patients that develop, especially ones that develop arthritis in the ankle joint and the joint below the ankle, the subtalar joint. If you fuse both those joints, that's more disabling, and that leaves you with a pretty stiff foot. And so the ankle arthroplasty is a good option for those patients especially. And I think as the devices have gotten better and the surgeons have become more experienced doing them, it really is the gold standard and gives people better function. And again, what's made the difference over the last 20 years? Getting better equipment, designs that make reliable bone cuts. Early mobilization, the better implants, the bone grows into most of these implants and makes them stable. And again, they've been developed good biomechanical philosophies to really make them last and be reproducible. And again, 20 years ago, there was like one total ankle replacement approved in the United States. Now there's several, at least 6 or 8 of them that are approved, and they've kind of again, that's been one of the interesting things, the exciting things. They've kind of all gone to some of the same philosophies, and these actually all the ones listed here. Well, all the ones are pretty good prostheses, and they each have their advantages and disadvantages, but they become so much better than ones in the past, and the techniques are reproducible. The one I use commonly, the first one, the end bone is an Infinity, have the majority of the market now, partly because they have a full spectrum of devices, and the techniques are reproducible. The results have been very good. This is just X-rays showing a few of the different devices and designs. And again, it could be hours of talking about all these designs and philosophies. This is the one system, the in-bone infinity. The infinity on the left is a bone sparing design where it doesn't take that much bone, so you have good bone stock left. It resurfaces the bone. You can see these surfaces that are kind of rough. Now they're kind of a trabecular metal material that the body actually your bone grows into this material, and you get a solid bond without bone cement. And so that's effective, and that sometimes is better, reduces loosening and maintains your good bone stock. But this is a nice device with that, without taking a large piece of your bone and joint, but resurfaces the arthritic joints. The in-bone system is very effective too for sometimes people who have softer bone or who've had fractures and have more of a deformity. And that's a device that's kind of an interesting device that is articulated and modular. It's put in a modular fashion. But again, you have to obviously for each patient choose a correct device and fixation. But these is an example of an X-ray of that in-bone device with this modular stem that goes up that helps stabilize it, just like the hips and some of the knees that have stems. And after an ankle replacement, people get can get very good motion and results, and it's very satisfying because so many people come back pain-free and are so happy because you know how it is having pain every day, and when that pain's eliminated, it's very satisfying. And again, that's one of the reasons I think orthopedic surgeons enjoy what they do, is that it's satisfying when you can do something that really changes people's lives and make them feel better. So in summary, the total ankle replacements, the designs are much improved. There's still, it's down now, but there's maybe a slightly higher complication rate than ankle fusion. It used to be the anterior wound, who have to make an incision in front of the ankle, which has sometimes is slower to heal. Although nowadays, because the procedures faster, have better techniques, there's less there. I'll show you, we're able to do custom cutting guides using the computer. That's sped things up, that it's the complication rates, fairly low. Again, the ankle replacement retains the range of motion of the ankle, and things keep on evolving and getting better, but it's certainly, I think, become the gold standard now. The normal ankle is a constrained joint. The bones and ligaments stabilize it, and again, just like the knee replacements, the metal and plastic resurface the joint and replace the arthritic bone that you have and get rid of that pain that you had. So just looking at the devices briefly, you have in all these devices, there's a trial during the surgeries. You plan that's going to fit precisely, but you have different trials to test it to make sure the fit is accurate and precise. The ankle arthritis, the unique thing about ankle arthritis is that most patients, some patients have a straight, their alignment's good, but most patients have, because of the arthritis, the ankle's crooked, whether it's from sprains or an injury, that the ankle either turns in or turns out. And in those cases, you have to reconstruct that deformity to make sure that the ankle's balanced, that your foot is straight under your ankle. And so you, like in this case, this ankle turned inward was pretty crooked, and then you release some of the ligaments and realign it so that the foot and ankle is straight, and that will wear normally. And again, just this one company's replacements, they really evolved over the years, that they've, their innovative thing was the stem component they first had, which solves a lot of problems and and is right for a lot of people. And then they had this, what I'll go over briefly, is the prophecy, where you take a CT scan and get 3D cutting guides. And now they have revision components, where for ankle replacements that loosen or fail, or people that have less bone stock, there's special bigger components that can accommodate that. And then the Infinity, which is a takes less bone and is be done through a smaller incision and things like that, is an effective device too that we've been we're one of the centers contributing to their national study on that prosthesis. So again, just a view of the prosthesis, the metal and plastic components, the ingrowth on the sides. These are pegs that kind of help additionally secure it and to fixate it, and then your body grows into the metal part. The plastic part's modular, so that if it does wear out, it can be removed without removing the metal parts. So this design, like I said, is low profile design, and has 5 different sizes. It preserves bone stock. And one of the more interesting things they've come up, and this is, well, now I guess another company has this now too, but there's the 3D printed custom cutting guides using the Prophecy system, where the patient has a CT scan, and from the CT scan, they're able to make these 3D cutting guides based on your anatomy, the patient's anatomy. So then in surgery, these are sterile and can be pinned to the bone to order to make the precise, accurate cuts for the patient. And it reduces surgical time, reduces the steps, and makes things more precise. And again, this is an example of a 3D cutting guide. This is the plastic model of the patient's bone made from the CT scan, and then this is the plastic cut, the 3D printed sterile cutting guide that we pin to the bone, and from that it can make precise cuts. This is just a kind of a schematic of how precise it is in doing that, and then we're given a plan like this that tells you, what size most likely will be, where it'll fit, and it helps in preoperative planning from that CT scan. So the Prophecy system is almost like a robotic system where it helps you plan and make more precise cuts. And these are just examples of the different plans and how the implants, these are the cutting guides, and this is how the implant will look when implanted. This is just a schematic of how we pin the 3D printed sterile cutting guide onto the bone, and then from the pins we can put the cutting guide and then make the cuts and remove the arthritic bone. So the studies have shown that the cases are very accurate within a few degrees of the target, and it's accurate, it's reproducible, and probably and more as accurate as any instrumentation. So that's the continuum of prostheses that we have, and again, excellent devices and an excellent solution for this problem. So there's a learning curve to total ankle arthroplasty, but again, it's become the gold standard. I think we've extended our indications with people with less bone quality, of older people with bone quality that might be poor or might be soft, or there's devices like the one with the stem that could work better. We could correct quite a bit of deformity with the ankle, new ankle replacements now, and we could extend the ages. I mean, we used to be hesitant about doing it in people who are too old or too young, but now the longevity has been proved. We can do it in younger people, just with the idea that they might need additional operations if it wears out, and in older people where we can accommodate for some of the bone quality. So the preservation of ankle motion is beneficial for most people, and most people want their joints to move, and I think people like that. It's become very reproducible, and the complication rate's low, and people's gait is better with ankle replacement. So that's, again, been an exciting development, and really, I think, like I said, the gold standard now. And it hopefully avoids arthritis in the surrounding joints, and you have less problem with other parts of the foot in the future. So it's a complex procedure with a learning curve. It has the modern ankle replacements are lasting again, we've only been doing them commonly the last 15 years, but they're lasting, getting to the longevity of hip and knee replacements of 20 years or more. So I think we're headed towards that, and that's good. And the gaits improved. The results are more predictable. Patients are very satisfied. At 10 years, the vast majority are in and functioning well. The systems continue evolving and getting better. The patient selection and the education, all that's critical. But again, it's the gold standard and excellent systems. At the end, we'll take questions and if on it. But again, I think that's been an exciting part of orthopedics. So moving on to another exciting area, which I guess when I started, I never thought it would be this exciting, but bunion surgery. I mean, everyone I think probably has heard of a bunion or knows kind of what a bunion is. Bunions are very common, probably 23% of one of every 4 people probably has a bunion. They're progressive. As we get older, bunions will progress and get worse. They're more common in women. They're more frequent with increasing age. There's a hereditary component. I mean, if your mother had a bunion, there's a good chance you'll have a bunion. And people say that all the time. I don't want my feet to look like my mother's feet or something like that. But there's a predisposition with tight, fashionable shoe wear. Fortunately in the desert here, we can go with open shoes and we don't have to, and I think some of the high heels and things like that aren't as fashionable anymore, that you don't have to wear those. But there certainly has, in the past, was a predisposition to high heels and tight shoe wear. This is just illustrating a bunion surgery, but the main indication for surgery for bunions is pain. And but there's a multitude of different bunion operations. In fact, there's over 100 different operations for bunions. And bunions, I think because of that, bunions kind of have a bad name. It's that when you've all probably heard of friends who had bunion surgery that hated it, or it was painful, or it came back, or they had problems. And so it kind of has a bad name to it. Like I'm saying here, it's a high rate of, in the past, there was been a high rate of recurrence and a high rate of patient dissatisfaction. And again, just going back to the definition of a bunion, bunion or hallux valgus is, your crooked big toe, that the big toe moves outward and you have a bump on the side of the foot. Bunion, I think is the Latin word for turnip. It's that, growth on that bump on the inside of the foot. It's actually not a growth, but it's the bump. And I think what we finally kind of realized in the last few years really is that there's been a lot of different bunion operations and ways to correct bunions, but since it wasn't consistent, there was a chance of recurrence. And I think we've come to realize that bunions are actually a 3-dimensional, not just a 2-dimensional problem, not just the bunion, not just the toe moving one way, it's the toe rotating and moving one way. And I think that's been the real innovation with some of these modern 3D corrections of bunions. And so this new technique corrects the rotation of the metatarsal. And there's several different, the lapoplasty is a description of one company's technique of 3D reconstructive bunion surgery, and they've done a very good job of publicizing and marketing that. Other companies have now come up with devices doing similar things, but I think they've all come to the realization that this technique is the best way to correct bunions and have a lasting correction. And in my experience too, I've really been impressed with the results in correcting bunions, because in the past it's been, the other procedures have not been consistent. So and again, it's very exciting. It's really an exciting area because it really, I think we finally saw that we go correcting the source of the problem is really solves this very common problem that's been not been approached correctly in the past. So as this shows, this is a straight foot, but this is where the bump occurs, this medial part. And the foot's got a lot of bones, as you can see here. The source of the problem, though, is this joint, which becomes unstable and lets the metatarsal move out. So the symptoms of bunions are pain, swelling, pressure, numbness. Certain tight shoes make it worse. The problem is that big toe, all the tendons insert on the big toe, not the metatarsal bone. So any difference in forces can offset it and make the toe crooked. So like I said before, there could be a genetic predisposition to it. Or there's, can be biomechanical imbalances. Footwear could aggravate it. This is a common scenario where you have a bunion, but again, it's not the growth, not the bump on the toe that's growing. It's back here where the metatarsal's moving and rotating, and then the metatarsal head becomes more prominent, and then it causes secondary problems like they're starting to develop a hammer toe here. So hammer toes are frequently associated because they're pushed up. There's not enough room, and again, footwear can contribute to it. Narrow high heels, can certainly exacerbate bunions. Bunions can get worse over years if they're not treated. The joint can become arthritic. You develop calluses that you get the crossover second toe, the hammered toe, the dislocated toe, bone spurs. You can get metatarsalgia, pain on the bottom of the foot. All problems as this gets worse. And the good thing about the technique I'll be describing is that, significant severe bunions and deformities like this could be corrected reliably and well. And in the past, this was more of a challenge with the previous techniques. The conservative treatment, you could use pads and toe spacers, inserts, orthotics, things like that. Obviously the most common thing is to just wear wide, comfortable shoes or sandals if you have a mild bunion, and that frequently relieves it. Most of these spacers and pads don't provide long-term relief, but they can help a little bit. And again, if the bunion doesn't hurt, you don't necessarily have to have it fixed unless it's severe or you're causing a hammer toe or a dislocated second toe or something like that. And like I said before, the misconception is that people think, okay, I have a bunion, I have this bump on the inside, I just need to get that shaved off. But the problem isn't in here; it's not the bump. The problem is back here, and that's really what this technique, and I think we've come to realize. Like I said, this joint's unstable, and the foot's out of alignment. It's called pronation. The foot's may become a little more flat, and that affects other areas of the foot. And correcting it, I think patients really feel better and have a more stable foot. And again, I mean, the exciting thing about this procedure is most patients that have it on one side, frequently it's bilateral. You have bunion on one side, you have it on the other side, and they almost all come back for the second side because they get such good pain relief and are happy with the result. So, and these are just x-rays. This is a normal foot showing, straight metatarsal. This is a bunion where, the foot's wider. You can see a little bump here. The bones have separated, and it looks a little subtle at first, but the instability is caused here where this joint's spreading out. And then this is another x-ray showing severe bunions where you can see how wide that foot is. And it's not that this has grown, it's that you have that instability in the middle of the foot that's allowed these metatarsal bones to move and that foot to become wide. At the same time, these second and toes are crossing over and dislocating, causing secondary problems. So it's multiple problems have occurred now from this, and that can all be corrected at the same time. But this procedure can be reliable doing that. So, like I said before, bunions are a three-dimensional problem. It's the rotation of this metatarsal as it rotates out on this unstable foundation, as they illustrate here. It's leaning sideways there, and then allows the metatarsal to elevate, puts more pressure on the second toe. Because it rotates, you're wearing the joint down eccentrically. The sesamoid, these little bones that are in the flexor tendon, are kind of pulling in the wrong direction, and the whole thing becomes out of alignment and contributes to the pain. So in the past, traditional bunion surgery, there's all sorts of procedures, but we did something to correct the bump, either shaved off the bump or cut the bone and shifted it over. The problem with this is initially it looks great, but it doesn't correct the source of the problem, the instability at the base. And the point is, your big toe, that's where all your motion, most of the motion in the foot is. This joint at the base, it's kind of like we never wanted to fuse a joint that and decrease motion, but this joint doesn't have much, has a degree or two of motion anyway. It doesn't have a significant amount of motion, but it can lead to instability. So the key to this procedure is by stabilizing this joint, we retain this joint, which is the key to your the foot function. So again, by shaving the bump, that does not address the unstable joint. So that this will only damage the joint there. That doesn't help that. So we need to stabilize the foundation. And again, in this case, it looks good initially, but you just basically cut away half the head of the metatarsal bone, and you haven't solved the problem. And this can recur. Just as this X-ray illustrates, the foot's still wide. This is pushed over, but that may keep on moving, and your deformity will recur. I think we've all heard of people who have had recurrence of their bunions, but with this procedure, the chances of that are much, much less. So again, it looks good on the outside, but it can come back and be a problem. Now with the three-dimensional bunion correction or the Lapiplasty, the point is we're rotating the bone back where it belongs and stabilizing it here at this joint by fusing this joint. You don't lose much because this joint doesn't move much in the first place, but this joint's now stable, and I think people feel better because it's stable and less chance of recurrence with these two small plates. So that's what it looks like. So anyway, there's different techniques, but there's these precise devices that help to correct it and get you to your correct alignment in there with these clamps and devices during surgery. These two small plates fixate it and hold the bone in the proper alignment, and really give you permanent correction. So so this is an example where this joint's now corrected permanently, where this metatarsal is aligned well. This metatarsal is still very crooked. The toe looks okay for now because you push the head over, and that's the anatomy's off, but it looks good cosmetically. But this can continue moving over and become a problem. This procedure, the beauty of this procedure is it corrects the source of the problem, doesn't just mask it for a while. And so again, this illustration of that concept, that you've got it, your surgery is reproduced back to what a normal foot looks like, not just made a, you haven't made a straight bone crooked. You've realigned the joint and solved the problem of instability. So the recovery's, fairly good. I mean, people are not put in casts. You're in a soft dressing in a boot. You can put partial weight on it in just a few days after surgery. You're in a walking boot for 4 to 6 weeks. After a couple of weeks, really full weight bearing. And then after 6 to 8 weeks, you move into normal shoes, regular shoes. And the results are good. I mean, you have a couple little incisions here, but cosmetically it looks very good. The foot's straight. Again, there's permanent good correction of the hallux valgus. Just with the technique, you correct the deformity, you prepare the joint, and you secure it. This is just kind of an X-ray appearance of what's done. But in any case, it's all precise devices made to realign it and restore the normal anatomy of the foot. Again, just an X-ray appearance of that. Again, these are little small titanium plates that are in there, so there is some hardware there, but not a lot, and it's not enough hardware to set off a metal detector, but it's very strong hardware because it's a biplanar plating technique, and it's and allows you to weight bear earlier. So again, the key to this procedure, I think it's the most exciting thing. It does make sense because it fixes the root cause of the problem. It doesn't just mask the problem, and you really rotate the metatarsal back group of lungs and solve the cause of it. Again, patients walk within days. They're not in a cast. They're minimal. They're less time off work, and it really is designed for permanent correction. Thanks. So that kind of summarizes that. I think again, the bunion correction, lapoplasty, three-dimensional rotational reconstruction has been one of the more exciting things, and I think it's really solved a problem that we haven't in the past dealt with well. And I think that's been, again, one of the more exciting things in my career in foot and ankle surgery, in addition to total ankle replacements. And I think both these things are reasons I enjoy still doing foot and ankle surgery. Thank you for your attention, and I'll take any questions.